in order here. Morning, Chris. All right, if I could have everybody's attention, those of you in the audience, if you want to continue to talk, if you would, go back out in the lobby. We have our first presentation from the folks from hospice. So, ladies.
Good morning. Thank you for the opportunity to be here. We'd like to talk to you a little bit about hospice care in Mississippi. My name is Tawana O'Rear, and I currently serve as Chief Operations Officer, Sanctuary Hospice in Tupelo, Mississippi. We're a nonprofit organization with a freestanding 24-patient inpatient facility, and we also provide home hospice care to 18 counties. We're a faith-based organization that was built by the community to provide a place of comfort and refuge for dying patients that had no place to go. Our founders believed that end-of-life care should not be limited to hospitals and nursing homes. They had a vision for something better, a vision that those without a caregiver should have a place to spend their days surrounded by loving and caring professionals. After an abundance of fundraising and federal legislation to make it possible, our doors were opened in 2005. To date, we have cared for almost 7,000 patients and raised $1.5 million annually to ensure our mission continues. Our fundraising success is evidence that our community understands the importance of quality end-of-life care, and as we come before you today, we hope that you share that belief as well. I'm here today in the capacity of President of the Louisiana and Mississippi Hospice and Palliative Care Organization and our affiliate, the Alliance for Advancement of End-of-Life Care. LMHPCO is a nonprofit educational organization with a simple mission of improving the quality of hospice and palliative care in the two states. Our affiliate, the Alliance, monitors Mississippi and Louisiana legislature and Congress for any legislation that can affect hospice patients, the providers who care for them, and the industry itself. In 2018, there was close to 20,000 patients served by various hospices throughout the state. On any given day, over 4,000 patients were receiving end-of-life care, including symptom management, skilled nursing care, personal care assistance, as well as spiritual and emotional support. As you can see from these statistics and the ones in your packet, hospice care is an invaluable part of the healthcare system. The importance of ease of access to hospice services cannot be overstated. In a state where socioeconomic status creates significant challenges to healthcare needs, we ask that every effort is made to ensure that dying patients and those caring for them are given the same opportunity you and I would be given to access the best end-of-life care available to them. Today we ask for your consideration on 3 items: changes to the Medicaid hospice election form, more systematic uniformity to pre-authorization timelines, and protection of pediatric concurrent care. And I'm going to ask that Tanya come and share with you more details on those 3 items.
As Tawana said, we thank you for allowing us the opportunity to come today and raise to you our concerns in basically 3 areas. I'm Tanya Hall. I am the Regional Vice President of Operations for Heart of Hospice. We've had the privilege of serving the residents and community of Mississippi for the past 3 years. Myself, I've been privileged to be able to serve hospice industry in Mississippi for the last 19 years. And have seen a lot of things change, and some of those things are definitely for the better. The 3 areas that we mainly bring to you as of concern today, the first one is this form here that is sometimes referred to as the election of benefit or the notice of election. And one of the things that we want to bring to your attention is Medicare also requires the same type of form. And what we have seen is Medicare has one process and Medicaid has another. So there is definitely, the first thing is the duplication of work. So what that means is when patients or beneficiaries are dual eligible, which means they have Medicare and Medicaid, in which Medicare is always the primary payer for those particular patients, Medicare requires us to do the form that I just showed you, also the certification form, and the recertification form. The problem is with a dual eligible beneficiary, whether we're going to bill Medicaid or not, Medicaid requires us to also do their forms. And their forms are different than the Medicare forms. So there's a duplication of work. We're doing 2 sets of forms for every dual eligible beneficiary, whether the forms are required or not. The second thing here you will see is redundancy. The Mississippi Medicaid Administrative Code, page 7, letter B, number 1A through D, states that the election of notice is required with initial election of benefit, but the form shows differently. The form requires us, for the beneficiary, to re-elect the benefit with every election period, where the code states that that's not required. It's just required to be signed one time throughout the hospice stay. But the form requires it to be signed with each benefit period. So there's redundancy of work. The last thing that you will notice here is difficulty in getting family members to actually re-sign the election of benefit with every certification period. You've heard Tawana reference a lot skilled nursing, long-term care with patients that receive our services. Most of us know that residents that reside in long-term care are not there by choice. It's because their family are unable to care for them and many times live many states away. So in order for us to continue serving that resident in that facility, that form has to be signed with every benefit period, which in hospice is 2 90-day periods and then subsequent 60-day periods. It doesn't just apply to long-term care. We have people that live in their homes that are also dual eligible or Medicaid only. In that facet of care, they don't have a lot of times the ability to sign for themselves. They have power of attorneys, they have significant others, and they may live in other states as well. We serve a very impoverished community, a community that a lot of time doesn't even have transportation to go visit their loved ones. So to enable them to sign a form or send it electronically or by fax is just not feasible in our industry. So we come to you today asking you to align the Mississippi Medicaid election of benefit or notice of election with the Medicare notice of election so that the forms and the processes are unanimous. Another issue that is just kind of on the radar, we're just going to briefly mention this, is pediatric concurrent care, which is care to those who are under the age of 21. Right now, the federal government is considering eliminating the benefit, and if this should occur, we ask you as a hospice industry in the state of Mississippi to support concurrent care of the youth of Mississippi. And then the last thing that we have to propose today is something that we identified after the presentation was put together. But in the state of Mississippi, as you know, we have traditional Medicaid, and then we have the MCOs, which are Molina, Magnolia, and United Healthcare. In the hospice pre-authorization process, in order for us to provide care to the people of Mississippi that have those payer sources, we have an authorization process that's required, and every one of those payers have a different authorization process. So for instance, regular state Medicaid is 10 days. Molina allows us 24 hours. Magnolia and United Healthcare allow us 48 hours. That's collecting data to support eligibility for that patient, sending it to a physician to get a signature, and I don't know if y'all know how that goes, which can take weeks. But they're wanting us to be able to do that in a 24 to 48, most of the time, hour period, which is almost impossible. So we come to you today asking you to make all of the payers have the same authorization process and timeline, and what we propose is 5 to 7 days for all payers. So I want to thank you again for allowing us the opportunity to voice our concerns, and we ask that you take those into consideration. And you want to conclude?
Thank you, ladies.
Questions?
Any questions from committee members? Representative Hines?
Thank you, Mr. Chairman. How many palliative care hospices are now operating for juveniles in this state? Do you know?
Jamie, do you know how many pediatric palliative care hospices we have in Mississippi?
30 hospices in the state that pediatric patients.
Around the state? How many are west of I-55 and north of I-20? How many are west of I-55 and north of I-20? Will you check and let me know? All right. Thank you.
Representative Yancey?
So this is Jamie's expertise, so I'm going to defer to him.
Sir, if you don't mind, how about going to the microphone?
My name is Jamie Boudreau. I'm the Executive Director of LMHPCO. The ACA mandated that all states provide concurrent care to anyone under the age of 21. So that allows them to seek curative treatment as well as hospice support for those kids that are facing a terminal illness. If the mandate is struck down by the Supreme Court, the pediatric concurrent care mandate also falls with it. And so several states are now in the process of mandating, even if that falls, that children under the age of 21 can receive both hospice and curative care at the same time, and that Medicaid pays for both of them separately.
Any other questions from the committee? Ladies, thank you. We appreciate you coming down and presenting to us today. Thank you. Next up is nursing homes.
Thank you.
Mr. Beebe, you may begin when you're ready.
Thank you. First of all, members of the committee, I'd like to say good morning. My name is Bobby Beebe. I'm with the Mississippi Healthcare Association. We represent nursing homes throughout the state of Mississippi. It's our understanding today that the presentation was to focus on Medicaid and our industry and how we work together. So I'll have a little brief presentation of what we do. As a quick backdrop, I'd like to talk about how highly unusual the year 2020 is. I don't know about the rest of you, but we're now facing Hurricane Storm Zeta. We've run through all the Greek alphabet coming soon. So here we are facing COVID, hurricanes, and if my memory's right, this is the 7th time something will hit between Louisiana and Florida for us to face in our industry, along with all the other things that just go along with our daily task. Quite amazing, quite amazing. So therefore, illustrating those challenges that we have, we'd like to talk about in our slide presentation some of the things that are good in our partnership with the Division of Medicaid. And I use that term very closely because I feel like through the years we've embraced the mission of working closely with Medicaid in an effort to serve the elderly throughout the state. Later you'll see in our presentation, but there are nursing homes in every county of this state with the exception of Issaquena. So we touch lives throughout the entire population in the entire state. And in Issaquena, it's a combination of the Sharkey Issaquena two counties together because it is so very rural. You can see in slide 2, in the year 2015, there was a report published that discussed the reimbursement and cost report changes to how long-term care is paid for by Medicaid. There was an ask back in the year 2013, 2014 for us to work with the division to work around some changes that would make it better for both the industry and the Division of Medicaid. One of those processes was a goal of being budget neutral, which we believe we achieved. And in that model, it has worked very well from 2015 going forward. I would like to state publicly that we had a good working relationship and have stayed with that with Medicaid throughout the time. We did meet many, many times to discuss what would work best for both parties. On your number 3 slide tab, you will find that as we work through that reimbursement process, there are some quick points of how that's developed for our payment system. We have a direct care component, which comprises of what our nursing costs, CNAs, medical supplies, direct things that are for that patient. Care-related relates to the food cost, our director of nurses, activities, social, consultants, and those persons that are on the peripheral every day working with those residents. An administrative and operating component, which handles our dietary staff, laundry, housekeeping, electric, food, water, utilities, etc., repairs, and insurance. And then last but not least, there's a property payment that handles depreciation, property taxes, and then whatever lease or your amortization to your loans would be. Those are compiled each year into a cost report, and they produce the rate that is for an individual home. And then the facility receives that rate each year, and quarterly is updated based upon acuity of the patients that are served in that location. Each January, the rates are set for the upcoming year, and they are adjusted quarterly by a case mix acuity level. And I'd like to describe that for you just briefly. When a person comes into the facility, there are nurses on staff that complete a 40-page report. That 40-page report has many, many questions about the needs and level of care for that resident. This is used nationwide, but that's what helps determine the need for that patient amongst other patients. And so the quarterly rate adjustment is only based on the acuity of that home. It may go up or it may go down based upon the review of the nursing staff for that patient. Many, many items: medication, mental status, the help that they need, bathing, eating, toileting, grooming, etc. One request that we would have is, through time, there's currently a federal guideline docket and there's a state guideline docket for this 40-page booklet. One ultimate request would be to go to the federal guideline docket so that it keeps consistency with what we do throughout the state. Through the years, the nursing homes have worked to maximize the bed assessment to draw down additional federal funds to Medicaid. This contributed $94 million to the budget for the year 2020, according to the budget request for Medicaid, and will draw a 3-to-1 match. So basically right now, each day we pay a $14.08 bed assessment for those persons that are living in the facilities. That is drawn up to the state, and that brings you a federal match. So the $14.08 is based upon the rates that are currently charged, or up to 6% Medicaid, and will draw a 3-to-1 match. So basically, well, we have an echo. I feel like I'm in Colorado today. Thank you. So therefore, this is an excellent program that helps produce additional dollars for the state, along with the federal FMAP that comes in. What I'm quickly trying to say is that Medicaid and Mississippi should be proud of a reimbursement system that currently is both very strong for the providers and good for the state. You know, when we work together like this, we come with good outcomes. Slide 7 shows you the cost array of different Medicaid providers throughout the state. And if you'll go down to line Y, toward the bottom of that page, you'll see what nursing homes were for 2017, 2018, and 2019. According to my math, basically if you take 2017 to 2018, there was a 1% growth rate in the cost. 2018 to 2019, there was a 1.5% growth rate to the cost. And we will have to wait and see what 2020 does because, again, COVID has turned all of us upside down. What I'm trying to portray to you is that by working back in the years 2014, 2015, and working together, we have a very healthy system, but it is not a runaway system. And so we're here to say that we appreciate what we're doing, and what we're asking for are simple changes to make us better, and we want to illustrate that today. Over the past 15 years, nursing homes have been stable in both reimbursement and occupancy. And so I have a bar graph there coming up that's green and blue. And I do want to disclose that the base number is 15,000, so you're going to see a little larger gap between the green and the blue than if we use the base number is 0. But we chose the 15,000 because if you'll look from the year 2004 on the graph, but I have placed on the snapshot 2009, which is about the midpoint, through 2019. In 2009, we were 88% basically occupied. In 2019, the draft report is still yet to be published, but the draft shows about an 82% occupancy. So if you look across all those years, basically what's happened is we're a very stable industry, and persons would ask, well, how does that happen when you have an explosion in the elderly throughout the population? Well, there are a couple of quick snapshots that make those changes. There are a lot of residents that enter our services later in life now, and when they do, they're at a sicker stage of care because there have been many more home and community-based waivered slots that individuals use in the community. And then there's also assisted living. So there are many other processes out there that weren't back in the 80s and 90s earlier. We'd like to say that our industry meets with the division generally on a quarterly basis, try and foster good communication with the Division of Medicaid. They update us on policies and any pending changes, and we do appreciate that ability to all get at the table and discuss what are important to us and them. The big factor for this year in 2020 is COVID-19. In March, as you all remember, this came on the scene, and in our industry in mid-March, we were basically instructed to place a bubble, if you could, if at all possible, on the residents that we care for. So therefore, visitation stopped, and many things in the outside areas were not brought into the facilities. So we've tried to be very careful about what the exposures were for our residents. One of the things that popped up was testing. Back in May, there was a National Guard group, and I have to say the state of Mississippi was unique. In May, every employee and every person who lived in a home were tested, all within a matter of weeks. The testing has proved to be a great way to try and check and watch for new outbreaks. And so in the facilities today, depending on what county you live in and the outbreak situation of that county, we either test weekly, bi-weekly, or in some very rare happy cases, monthly. But we are testing on a regular basis to try and contain those outbreaks. What's happened to us, though, as we go back and think about that green and blue chart, that 88 to 85% level occupancy has dropped. And so as that's dropped, that's placed more pressure on our industry to remain strong and survivable. Those drops occur due to the fact that the hospitals can't utilize their normal surgeries and their elective procedures because they are taking care of the sick and are trying to keep a reserve of available beds for the COVID. This in turn drives labor costs for what we do in overtime and stress, because all of the healthcare industries are trying to work out of the same pool of employees, and yet when the employees are sick, those individuals can't return for 14 days, so it increases the demand on the limited pool of labor and employees to serve the elderly. When we came and discussed and met with you back in May, there was CARES Act funding. At that point in time, there had been 2 sessions or 2 sectors of CARES Act funding. There has now been a third later in the summer. However, for all of you that read and watch the news and see what's happening with the federal Congresses, et cetera, we are seeing that drying up quickly. And so in May when I was here, the CARES Act funding was very helpful. With that drying up, we are beginning to feel the pain, and we are going to ask for some help from Medicaid. Because as we know, we don't see COVID going away anytime soon. Just anecdotally off the actual presentation we discussed yesterday with Dr. Dobbs and some others, there is a plan for a vaccine, and what would happen if the vaccine is available. There will be a distribution network through CVS and Walgreens. It is really based on the ability to keep that in what they call the cold chain, because the vaccination has to be at a greatly reduced temperature, sometimes minus 70 degrees, so that it stays pure before it can be delivered. We hope that comes at the end of the year, but even if it does, that's for healthcare workers and for nursing home and assisted living. It still doesn't take care of the population. So we're looking a long term out before this goes away and we have reached any type of herd immunity or a chance to be safe in the community. For years, I've read the Kiplinger letter. The Kiplinger letter is a great synopsis of what's going on in the world. I never thought that we would make the Kiplinger letter, but in July, Kiplinger says that nursing homes faced both a very strong challenge based upon demand and when the pandemic will be truly overcome. What that's basically saying is if you'll watch nationwide and then what happens here in the state, for an industry that is operated at 88, 85% occupancy, the national level has dropped to 76.5%. And this is August numbers from the National Investment Center, NIC, which I don't know if you recognize or not, but they gather data from all over the country. My experience for what I do throughout the state, our company is at about 71 to 72% on any given day now versus where we were in February and March. That's a pretty strong drop. Under our reimbursement system, there was a floor or a weighted cost average that caps at 80%. We're asking to have that floor waived for the year 2020 due to the fact we've had such a strong reduction in census and we don't know when this will bounce back. You know, a lot of people have a lot of prognostications and thoughts that come in their mind, but if you just take and look, if I could run back to 90% tomorrow, my overall weighted average wouldn't come back for the 6 months that I was already down. So the division is actually looking at this proposal with us. We're asking for a waiver. We're not asking for a change for years over years over years, but again, because of COVID, this has created a very different time in our lives. On your final slide, COVID has required substantial outlays for personal protective equipment, testing, staffing, pay for staff, not only in overtime but in other areas, because we are working to isolate and cohort residents that have either been exposed or actually positive for COVID against those that are not. So you break your building up into zones. You have an infected zone, you have a recovering or a isolation zone, and then you have their zone of patients who have not been exposed. Well, that increases the number of people you need, and it also increases the amount of protective equipment that you use and the testing, et cetera. So during the year 2020, before the COVID, Mississippi was blessed to have an FMAP of 77%, which Mississippi is the highest FMAP in the country. Due to COVID and the proclamation of this emergency, we're receiving a 6.2% add-on. So when you take those and put them together, we're basically at 83.9, 84% FMAP. It's our understanding that this will last until March of 2021 because the current proclamation brings you through January, so therefore the matching dollars would carry through the end of the first quarter as we speak today. It's our request to seek some additional funding due to the COVID costs that we're incurring. And in neighboring states that are adjacent to us, this is already happening through an add-on that is for COVID. So the example that I have in your pages today is the state of Louisiana, which they actually took a $12 a day add-on and made that as a simple one-line item. It will track during the time of the COVID proclamation, and then it would go away once that has been released. So in summary, there are a lot of good things that we appreciate and work with the division on, and that try and keep us as a healthy industry. But we do have some requests today to try and continue to make us stronger, to make the future, because we do know that what we do has service and purpose. And if I could close with just one observation, to make it in this business, you have to have both passion and compassion. You have to have compassion for the persons that we serve, the people that need our help. But you have to have a little passion for what we do, and you have to advocate for what we do, because there's not a lot of folks out there that are able to take care of the individuals that we're entrusted with for the daily operations. It's 24/7, 365. And so we thank you for a moment today. We appreciate your time. And I believe we have some other folks that are going to talk a little deeper about COVID.
Mr. Beebe, if
Yes,
you
sir.
don't mind, let's see if anybody on the committee has any questions of you.
I think Senator Wiggins does.
All right, Senator Wiggins.
Surely.
Thank you, Bobby. And I want to say I appreciate your work on the different things that have been done in the past, including the the managed care report that was done.
Yes, sir.
I wanted to go to your handout
Okay.
that you gave, and it's page 4, the Mississippi Medicaid provider payments.
Yes, sir.
Okay, which, so I will note that the nursing home payments, Medicaid payments, are the second highest to nursing homes in the state behind hospital services.
Okay.
And the three highest are hospital, nursing home, and pharmacy. Mine, are nursing homes, is that mandatory, or is that mandatory under Medicaid? I can't remember. You know what I mean by mandatory?
You're saying as a reimbursement.
Yes.
I would have to check.
Alice maybe can answer.
What are you asking? Is it for the bed tax?
No, under
no, I
the
think he's
federal
asking,
law.
is nursing homes a federally mandated program?
Medicaid saying yes.
Okay, thank you. All right, whereas pharmacy is not.
Correct.
Okay, thank you. And so under that, over the 3 years, the payments have continued to go up, and in fairness, if you look at some of these other ones, they've continued to go up. So my question is, what do you attribute the continual rise in the payments that the state pays to nursing homes?
Okay, so if I could maybe break that down in 2 or 3 quick responses.
So if I may summarize, because not everybody has it, in FY 2017, there was basically $800 million paid to nursing homes.
Yes, sir.
In FY 2019, there was basically $819 million, so a difference of $19 million over 2 years.
Okay, so if I could break that down in 2 or 3 quick areas. Number one, by working with the division back in 2014, 2015, there were enhancements to try and make this closer to budget neutral. And So we come in at a 1 to 1.5% cost increase year over year, per the example. And if my memory's right, because you've caught me without all my papers, but I'm going to go back to my memory, and if my memory's right, if you look at the medical CPI index, your cost factors on medical is over 4 to 4.5% a year.
And
Our sector-
for us laymen, what does that mean?
Well, that would mean that if you look at the medical sector year over year, it rises by 4 to 4.5%.
So there's a built-in 4% increase because of medical cost, or not built-in, but
No,
if there's-
sir, it's the fact that medical costs rise
That's what I meant.
basically 4.5%.
Okay.
The purpose of this illustration is to try and show that we believe we're a very fair bang for the buck to help take care of the persons that we're entrusted with. In addition to that, if you take this year alone at a 77% federal match with a 6.2% add-on, that's over 80% that comes from the federal dollars. So again, we believe we're a great bang for the buck. Last but not least, that's providing jobs in all counties with the exception of Issaquena, which are nurses, aides, housekeepers, administrators, et cetera, which provide a stimulus to each of those counties. So we do believe that our industry is good for the state.
And last question, if you can answer this, does Mississippi have I'll put it this way, a higher percentage of elderly than maybe a lot of other states?
I couldn't answer that without looking at a census or a statistical report, but I would say that the number of persons here have been stable through the years because of, as we mentioned earlier, home and community space, assisted living, et cetera, and just the natural science of medicine getting better. You know, people are living longer, but we're living better, and anecdotally, quite honestly, if you take just at my parents, you now can have something as simple as Lasix or a blood pressure pill, whereas before, 40 years ago, once you began having congestive heart failure and you didn't have those medicines, things weren't a great outlook. So it's allowed people to be not only much more active in society, but it's allowed them to live at home and live longer.
And live longer,
Yes, sir.
and we have to prepare for that. Okay, thank you very much.
Yes, sir. Thank you.
Senator Blackman.
Nursing homes care for our most vulnerable adults. Is that not correct?
That would be a fair statement, yes.
And do not nursing homes have protocols in place to deal with infectious disease outbreaks? Are you required to have protocols in place? I guess that's.
So are you trying to compare what COVID is versus other infectious diseases possibly?
I'm asking if you have protocols, if a nursing home is supposed to have protocols in place to deal with infectious disease outbreaks.
We do have some protocols for things such as the flu, et cetera. We do not have negative air pressure chambers or items like certain hospitals do. An example would be tuberculosis. If a person is tested for tuberculosis and found active, we're required to send those individuals out, and those individuals would be in a negative air pressure area, and they would go on if my memory's right, there's a medication called INH. They would take that medication for a certain number of days, and then at that point, when they're no longer considered actively infectious, meaning that they would pass that along to others, we can then bring them back to the nursing home.
COVID first began, there was a correlation between fractions that nursing homes had been imposed and high COVID numbers,
A great question, and I hope I have my paper with me. There was a study conducted not long ago, and it was by Brown University and two others that I can't remember off the top of my head, and it quickly showed the correlation between a community outbreak and the outbreaks in nursing homes. And if you just will kind of look at the nation right now and you'll watch how the maps go from to red for outbreaks, the Midwest is facing this now, and a lot of the other places who thought they were immune to this issue, it's really what goes on in the community is what ultimately happens in the nursing homes. And I'll be happy to share with you that cut sheet from the university studies. It didn't necessarily correlate with it being rural or urban. It didn't necessarily correlate that there was a facility that happened to miss one policy or have a difference in the way they did things. It was what was happening in the community. It had the direct one-on-one correlation.
Were those national studies or was that a study in particular?
No, ma'am, this is a national study. And-
Some correlations between infractions and household numbers in nursing homes?
Oh, well.
Okay, so you and I may differ on that answer. If y'all don't mind, I'll continue along this a moment. So, March and April, our industry was like everybody else. March and April, we had some N95 masks, we had some gowns, we had things just like everybody else. But did I have a warehouse of that? No. If you'll take this a step further, once we all began seeking N95 masks, gloves, gowns, etc., the Department of Defense took this over. I believe everybody would recognize what I'm speaking of. So in our company alone, we ordered bulk N95s, we ordered bulk alcohol gel. I'm going to tell you what, I never thought in my life that I could go buy a gallon of whiskey cheaper than I could get alcohol gel to take care of my people. And you know what? I bought it and hauled it in to make sure we could give that to our folks to provide for safety. Now, the masks that we ordered and the gowns that we ordered got hung up on the East Coast, the Department of Defense. So you're on your own still trying to get things done. So I can speak for our company. I can't speak for everybody, but I'll say this. It wasn't beyond us to get in a pickup truck and go drive two hours to meet somebody else to try and get additional masks. It wasn't beyond us to go try and get gowns and other things to meet the needs. Is it perfect? No. Did I ever think I'd see the day the CDC would put out a guideline on how to sanitize and reuse masks? We have it today. And so this thing was beyond any of our imaginations. I've done this 35 years. This isn't what they taught you in the books. You learn as you go. And I will try and close with the phrase that I did say at the end. We have to have passion for what we do, and we have to have compassion for the others that we serve. And I can tell you, we do. Now, to stand up here and say we did everything perfect and right, I can't. That's impossible. But nor could anyone else. And at each night, we're trying to do the best we can. And even today, we're still on allotments. All right? Well, if you go back and you look in the history of all of your orders, and maybe you used to order 4 cases of mask, and today I could use 10 cases. You know what the allotments are going to send me? 4. And I've got to do the things like the sanitations, et cetera, to reuse. And the production hasn't caught up to the needs, and we're all facing that same issue. Now, at least the cost has gotten a little better. There was a point in time we were paying $5 a mask and happy to get them. And you used to buy them for 88 cents. There was a time you could get the gowns and the other things for a much more reasonable price, and they jumped up. So, we were all doing the best we could. And I can quickly and honestly say that. If you will allow me a moment, while the other presenters are here, I will look through and I will pull that little Brown University report, and I'll be happy to share that with you, I promise. It's just that I have 3 folders, and it'll take me a moment to dig through that.
All right, Senator Bryan, did you have a question?
I think you may have answered this question between the time I left my office and walked in here, but
Yes, sir.
I was going to go over the Medicaid reimbursement. You said our normal Medicaid reimbursement was how much? The state's normal Medicaid,
The FMAP
yes.
was 77% for this year, according
Okay,
to
and then we had the 6 and
the
a
6.2
quarter.
add-on. Yes, sir. Puts you at 83, almost 84%, yes.
Now, in addition to that, the nursing homes pay a bed tax, which figures out to about 6%.
Give or take, yes, sir. It is capped at no more than 6%. That's correct. So
So roughly speaking, right now, it's costing the taxpayers of this state 10 cents to have $1 spent at a nursing home.
yes, sir, I would agree with that statement. I would.
And when we do that, we dump $1 into the Mississippi economy, and I understand not every single penny a nursing home gets goes into the Mississippi economy, but it's a mighty high percentage, and that money circulates in the economy, and there's a multiplier effect of that, and we get money back in the Treasury simply by having that economic activity.
Yes, sir, that's true.
And so, in addition to all of that, we do provide some services from some poor, sick people that need constant care, don't we?
Basically, all of them need care, yes, sir. The days of convalescent care have pretty much faded away, yes, sir.
Thank you. I'm learning from listening to Senator Wiggins' questioning of the witnesses.
Mr. Chairman, just was going to say those were leading questions, and back at you.
Mr. Beebe, I have one just clarifying question. On
Yes,
your,
sir.
Last comment about the neighboring states, and you referenced Louisiana paying $12 a day. I take it that's $12 per patient day.
Yes, sir, it's $12 per patient day, and it is a distinct add-on line at the bottom of the rate sheet, and it specifically says COVID-19 relief, and it is based upon the proclamation as long as that goes, which, as I mentioned earlier, because it is, the proclamation's through January, that would flow to March of 2021.
Thank you, sir. It's, all right, this needs to be the last one. We've got several folks to speak.
Thank you, Mr. Chairman. Just quickly, I thought I understood from your handout that the additional federal increase of 6.2% to the FMAP has not been allocated to nursing homes, but then I thought I heard you say to Senator Bryan that it has.
No, sir.
Could you help me understand that?
What Senator Bryan and I were speaking about is that normally, if we hadn't had COVID this year, there would have been a 77.7% FMAP. I feel good with that number. That's what this is. So we were at 77.76. So COVID came along, and because of the proclamation of the disaster, there was an additional 6.2% FMAP that began in March of this year. And so, in essence, for the current year, we have an 83.9, almost an 84% match as the federal dollars come into the state. My slide, or my bottom of the presentation is that for nursing homes, our rates have not adjusted or changed for COVID, okay? And that is what we're asking for some help and some relief on. When we were here in May, we discussed the CARES Act funding, which did send some dollars to the nursing homes. But from May until now, those have basically been used and evaporated, and we're trying to figure out how do we get through to Christmas, to get through to Easter, to get through to next year, because I'm facing a very large conundrum. You know, that is there's a declining sense of revenue and census and folks living in the home, and yet the costs are tremendously staying the same. And I promise to be brief, but if you'll allow me this, we're a little unique by rule and by regulation. And unique is what I say, if I have 40 people in a home, if I have 100 people in a home, or if I have 140 people in a home, there is a fixed cost area that's different than a lot of other businesses, and that is we're required to have an administrator, a director of nurses, a food service supervisor, an activity professional, a social service person, nurses, etc. Well, those don't scale like other businesses scale. So, in my opinion, we have some fixed costs that carry no matter what. And when you get down to a lower number of people, that begins to eat on you pretty quick. And we're facing that this year. So does that kind of help finish painting the watercolor? I wanted to be.
Thank you, Mr. Beebe.
Thank you.
Ms.
Appreciate your time.
Thank you, Mr. Beebe. And
Sir.
I think we have 3 more presenters.
Yes, Ms. Mitchell, I think did you want to present? Okay. Kyle, Mr. Lewis, go ahead.
I would ask you to be mindful that there may be some committee members that want to ask questions, and we're trying to keep on schedule here.
Well, good morning, and I just want to thank Chairman Blackwell, Chairman Hood, and all of the members of the Medicaid Committee for allowing us to have open participation in this important hearing today. My name is Kyle Lewis, and I'm the Senior Director of Senior Care at Memorial Hospital, Gulfport, where we oversee operations of 3 nursing homes in South Mississippi. We're also a member of the Independent Nursing Home Association. I want to thank Mr. Beebe for giving a great illustration of our positive relations that we've had with Medicaid over the years. I also wanted to highlight some of the challenges that we are seeing currently, as Mr. Beebe alluded to later in his presentation, and provide some numbers and operational impact for you for this. And this hearing will allow for that constructive dialogue and highlighting the many challenges that nursing home operators face in our continued goal of providing care to our state's most vulnerable population during this pandemic. Our goal as providers is to provide the most optimal safety and care to our residents, many of your constituents, and most importantly, all of our fellow Mississippians during this challenging time. COVID-19 pandemic has impacted the viability of skilled nursing facilities in a variety of ways. Since the beginning of 2020, and unfortunately we say now times pre and post-COVID, so I'll say pre-COVID, SNFs, which is skilled nursing facilities, have experienced up to a 6% decline in their patient population, with post-COVID numbers suggesting an average census decline to approximately 72% capacity as a result of potential residents choosing other care settings, as well as hospitals discontinuing or decreasing their volumes of elective procedures. As you're all aware, the U.S. Department of Health and Human Services announced and deployed 2 rounds of provider relief funds to SNFs to help combat the devastating effects we've seen in this pandemic. I just wanted to provide an example of the breakdown of this funding, and one of these fundings was phase 2. So just a breakdown of that, there was a $50,000 fixed distribution for each facility. Every facility in the state, it's that fixed rate. And then there was a $2,500 per bed rate for that facility based on what their bed capacity is, which equates to about a 100-bed facility, which is slightly higher than the average size facility in Mississippi. Equates to about $300,000 that the nursing homes receive from this Phase 2 Act. And this was to provide direct funding related to critical needs such as labor, scaling up screening and testing capacity, acquiring personal protective equipment, ramped up infection control practices such as installing UV lighting or air scrubbers and HVAC systems, and or routine facility-wide disinfection practices, additional biohazard medical waste disposal, and medical equipment, as well as routine testing. I just wanted to touch on a little bit of the routine testing component that we are in compliance with, both from CMS and the Mississippi State Department of Health. As Mr. Beebe illustrated, we are under a mandate to do routine and outbreak testing, and how that consists of is it's based on a percentage on that county positivity rate. Below 5%, it's once a month. Between 5 and 10%, you're testing once a week, and then above 10% is considered that red county of county positivity rate. You're testing actually twice a week. Just a breakdown of that testing component. Early on, we were fortunate to have the ability to have the National Guard and Mississippi State Department of Health come in and facilitate that testing and processing that through the state lab. As you can imagine, that increased the number of labs exponentially for the state lab. So what we have done at this point is contract with other labs coming in and providing that testing for not only our residents but also our employees. A critical step in controlling the potential spread and identifying those symptomatic and asymptomatic individuals. The approximate cost of the test is about $100 per test. So if you have on average 100 employees at a facility that you're testing at $100 a test, equates to about $10,000 per testing. Like I said, there are facilities that we have that are actually testing twice per week, so that equates to about $20,000 a week or $80,000 a month solely on testing alone for our employees. But it's a critical step in making sure we control the spread. Cost per day for biohazard pickup during an outbreak. In correspondence with some of the facilities that went through an outbreak, they were spending upwards of about $1,000 a day just to handle that biohazard items, the gowns, all of the PPE that was used and disposed of, which equates to about $30,000 a month or so as you're going through an active outbreak. Additional payroll costs related to hazard pay and agency staffing coverage. I do believe COVID exacerbated our critical shortage of nurses in the state of Mississippi. I think it's no secret. We have a critical need for nurses in Mississippi, and I know that's not the topic of discussion today, and maybe hope in the future we can have that dialogue on what we can do about some efforts in cost sharing and to promote our nurses to remain in the state. There's no shortage of applicants, but there is a shortage of instructors. So what we can do to help encourage, do some cost sharing for that, but that's a topic for another day. But it did highlight the critical need. A lot of facilities had to utilize agency staff nurses, which are outside of the state of Mississippi oftentimes. On average, for those CNAs, it's triple or quadruple the typical cost that you pay per hour for those CNAs or nurses. Typical cost for a CNA in Mississippi is anywhere probably about $12 an hour. For a staffing agency CNA, it could be upwards of about $45 to $50 an hour. For nurses, it could be upwards of about $50 to $60 an hour for these agency staffing nurses. So again, further exacerbated the need in shoring up our nurse base here in Mississippi. Overall health of our residents declined as a result of the lockdown, which has caused an increase in additional costs such as labs, x-rays, pharmaceuticals, and diagnostic equipment. As the guidance suggests during an outbreak, a facility must halt admissions to best safeguard the residents and potential referrals. So if a facility is in an active outbreak, it is advised that you stop admissions. You stop admitting folks until you can make sure you have that outbreak under wraps and you identify what the source is and control that. Obviously, you're not taking in, which can inundate hospitals in turn. Cost of contracting sanitation processes or procuring sanitation equipment for the facility. I know a number of facilities, regardless of the cost, the number one goal is safeguarding the residents that have installed it, air scrubbers or UV lighting to the HVAC systems, which run anywhere from about $1,000 to $1,200 air unit, which, depending on the size of the facility, can have anywhere from 25 to 30 air units. And again, I wanted to just illustrate this point from an operational standpoint of what the cost is of COVID to protect our residents. I was just speaking with a couple of nursing home administrators and operators this week, and they said, Kyle, there is a critical need. They're in a cash flow crisis right now, and they have to determine, can we make payroll or can we put some of these best practices in place to safeguard these residents? They're having to make that difficult decision. So as you can clearly see, the multitude of factors associated with rising operational costs to keep our residents and staff safe, paired with the loss of revenue predicted to continue for the next 2 years, Mississippi nursing homes need our state leaders, along with Mississippi State Department of Health and Medicaid, to come to a viable solution. As Mr. Beebe illustrated, there have been some neighboring states that have done an add-on per diem rate surrounding Mississippi. Alabama has done a $20 a day add-on. As we discussed, Louisiana did a $12 a day add-on. Tennessee was able to do a $23 a day add-on to their per diem. Arkansas did a direct add-on for employee wages that equals about $6 an hour for those individuals. And as discussed, the federal Medicaid assistance program increased by 6.2% to the state Medicaid program, yet we have not determined a structured program to help provide this for long-term care settings. And I do want to thank and acknowledge Mr. Snyder and his team for staying actively engaged with the Independent Nursing Home Association on a monthly basis. We would do quarterly calls with Mississippi Medicaid and then transition to monthly calls just so we can make sure that we all stay current on the state of affairs and potential plans. But as leaders, I think we need swift and concise action in order to maintain the viability of many nursing homes across the state. There are many organizations that are looking at unloading their nursing homes, may be based in another state, but looking at leaving the state of Mississippi because of some of these financial issues that they're going through with cash flow. Many facilities are seeing that concern. CMS recently approved the State Plan Amendment 20-0019 on September 15th to allow the Division of Medicaid to make interim payments to 14 community mental health centers by increasing the monthly average payments by an additional 25%. I think that's a great step in targeting a very essential need here in mental health in Mississippi. I want to also point out House Bill 1782, which was passed and designed to provide $30 million of CARES Act funds to eligible recipients for the procurement of PPE and COVID testing. This equated to about $2.1 million that was allocated to nursing homes across the state, which has a cap of about $10,000 per facility. And as I stated before, that would get you about one round of testing for that week for those employees. So it's a commendable effort to get nursing homes this money, but doesn't really scratch the surface on what that increased expenses are and the needs for these nursing homes. HHS, through Health Resources and Service Administration, distributed another $20 billion in a Phase 3, which is part of an ongoing effort to offer financial support to healthcare expenses and lost revenue attributable to COVID to equal about 2% of patient care revenue. Unfortunately, nursing homes were not included in this role, and it does promote the safeguarding of isolation rooms and other healthcare settings, and again, nursing homes not included in this. I did want to take a moment to have an opportunity just to commend and thank all of our incredible frontline staff that have remained steadfast in their unconditional dedication for caring for our residents. As we continue to navigate through uncertain times, we feel the heaviness of fatigue brought about by some of the deepest challenges, but we'll continue to find a way to elevate ourselves and, most importantly, the residents that have become family. We know yesterday is gone. We have today, and hope we can make tomorrow better than today. I urge the time is now to work together and ensure we provide solid footing financially for the benefit of our fellow Mississippians. Did I have any questions or comments about those numbers?
Any questions from members of the committee? Thank you, Mr. Lewis.
Okay, thank you.
Ms. Mitchell, okay. Next up then is Department of Rehab Services, Chris Howard.
All right, good morning.
Morning.
Let me go ahead and start. Y'all want to wait on the handout?
You can go ahead and start.
Okay. All right, good deal. My name is Chris Howard. I'm the Executive Director at the Mississippi Department of Rehab Services. Chairman Blackwell, Chairman Hood, members of the committee, thank y'all for having us out today. It's always exciting to come talk about the great things happening at the Mississippi Department of Rehab Services. So in looking at your handout, I know y'all asked me to come talk about our waivers. But if you look on page 3, I thought I'd give you just a quick 40,000 high-foot overview of what our agency does. So we are the state agency that's responsible for providing services to Mississippians with disabilities. We have offices from Corinth down to Gulfport, over to Meridian, across to Natchez. So we cover the whole state. We serve about 90 to 100,000 Mississippians every year through one of our 4 major programs. If you look on that second bullet point, those are our programs. We've got the Office of Vocational Rehab and the Office of Vocational Rehab for the Blind. These are the programs where we help Mississippians with disabilities prepare for, obtain, and maintain full-time employment. These may be individuals who have never worked before and want to go to work, want to become a taxpayer, and we provide services to assist them. Or it may be individuals who've worked for a number of years and maybe later are losing their vision or losing their hearing, or maybe they fell out of a deer stand or were in a car accident and have to rethink, how am I going to support my family? So we provide services there also. So we serve about 17,000 Mississippians through our vocational programs. Third bullet point is disability determination services. We provide the eligibility determinations for Social Security Administration. A lot of folks think that's federal, but if you have a constituent who files for disability, they go to their Social Security office, they file, it actually comes to our office, we review the medical evidence to make that determination. So we do that in Madison, and roughly 80,000, I think, Mississippians apply for disability every year. So we do a lot of claims reviews there. And then our last one is special disability programs, and this is Anita Nyack, who's with me today. She's over this program, and she oversees the administration of the 2 home and community-based waivers. So she's our expert, so if I can't answer anything, hopefully she can take care of that for me. Fourth bullet point, I always like to talk about this anytime I'm in front of a group of legislators. InSpark, which is through Mississippi State University, they do a return on investment for us. So when you talk about our vocational programs, the return on investment for the state dollar is 2.8. So what that means is for every dollar y'all appropriate us, once we put a person with a disability back to work, through tax gains and reduction in public assistance, you get your dollar back plus another $1.80. So that's about 180% return on your investment in our agency. So, I know the stock market's doing pretty good, but it's not doing that good. So hopefully we're worth the money there. And then the last thing, Project Search, I like to talk about this too. We brought this to Mississippi 2 years ago. It's a worldwide program, provides an opportunity for young adults in their last year of high school with intellectual disabilities to gain valuable work experience. So they go through a 9-month training program, and about 80% of those individuals get jobs after they're through. So there's a misprint there. I put 10 sites. Actually, it's 7. We have 7 going on right now. We had 10 planned, but because of COVID, 3 of them wanted to postpone until next year. So we've got 7 up and running. But I'll tell you, the demand for this program has really been strong. And for 2021, depending on COVID, we hope to have about 15 to 20 sites. But it's a great opportunity for young adults with intellectual disabilities to get that valuable work experience through working at a hospital or a host employer and getting ready for employment. So something really cool there. But again, that's just a huge overview of our agency, and I just want to talk about that before we got into the waivers. So if you look over on page 4, that kind of starts our waiver discussion. And our agency administers 2 home and community-based waiver programs. One is the independent living waiver, and the other one is the spinal cord and traumatic brain injury waiver. Among the various requirements for eligibility, the most important one to note on number 2 is the individual has to be nursing home eligible. So Senator Blackman, like you mentioned with the other group, these are vulnerable adults. These are individuals with significant disabilities. And through this program, we are able to allow those individuals to live at home as opposed to a long-term care facility. We serve about 4,000 Mississippians each year through one of these 2 programs. And the main thing we do is provide personal care attendant services. So we have what we call PCA go out there every day and help with daily living for that individual with a significant disability. If you look over down on the 4th bullet, it's based on individual need. It's not a one-size-fits-all. Our case manager, a registered nurse go out together, do the initial evaluation, and determine what that client needs. They may need 4 hours a day. They may need 8. They may need 12. It depends on the client's needs and their supports they have currently in their home. In addition to that, we provide about 1,500 of those 4,000 other services, such as home modifications, durable medical equipment, whatever that person needs to live at home as independently as possible. So a lot of Mississippians across our state rely on this service. Flipping over to the next page, our program services are self-directed. So, we don't just call and say, hey, we're sending Chris Howard to be your PCA for 5 hours a day. It is self-directed. The individual has an opportunity to interview the PCAs. The family has the opportunity to interview the PCAs and select the person that they want to help with that daily care. And then we also do background checks. Of course, we don't want to send a felon out to the house. So under state statute, we do background checks to make sure those PCAs are clear of any wrongdoings before we send them out to the house. And then when you look at our standpoint, our counselors, our case managers have a bachelor's in counseling. They have at least 1 year of experience in working with individuals with disabilities because, again, you're serving individuals with significant disabilities. So we want to make sure our staff are trained. They've worked with individuals with disabilities. They have the background to do it because when you're dealing with a group of vulnerable population, you've got to make sure you take care of those folks the best you can. Another point to note there, by providing personal care attendant services, we provide the opportunity for family members to keep working. You hear a lot of time that a spouse has a significant disability, has a stroke or what have you, and then the other spouse has to quit work to take care of their family. And guess what? Now the income source is gone. The person just quit work. that money coming into the family is now gone. So through this program, we can hire personal care attendants, send them out to the house to take care of those individuals, which allows the family members to keep working, keep paying taxes, and keep drawing that income. And then, of course, the fifth point, I guess everybody's probably talked about COVID. Again, because we are dealing with a vulnerable population, we have made sure that we provided masks, hand sanitizer, and gloves to our clients and our PCAs, because, again, we want to make sure we keep our PCAs safe and most importantly, our clients safe as well. So we're doing that in addition to. Looking over on page 6, one of the things I was asked to do was talk about managed care. Under Mississippi CAN, we are actually exempt. The waiver programs are exempt from managed care. So this is kind of a hypothetical of what would happen if we were under managed care, I guess would be the best way to say that. So the first thing, managed care may reduce quality of services by seeking to pay a set rate. Again, personal care attendant services are based on need. You know, Senator Blackwell said you and I are both clients. You know, just because we're both clients doesn't mean we both need 5 hours a day of PCA services. You know, based on your level of disability, for example, and the support you have in your home compared to what I have, you may need 4 hours, I may need 8 hours. So again, it's individual based. We go in, we evaluate the situation, we evaluate the person's level of disability, we evaluate their family supports, and come up with a plan of care to make sure that that person is able to live at home as safely as possible. In addition to that, we provide, like I said, additional services. We do a lot of home modifications. You know, a lot of roll-in showers, a lot of ramps, a lot of widening doors. And again, these are not, you know, one size fits all. You know, just because two people need a or need a bathroom modification doesn't mean we need the same one. Houses are set up different. We have our own assistive technology department, and they go out and draw the specs up for these home modifications. Because depending on where the bathroom is, where the toilet is, how many grab bars you need, we have to design those based on the person's house and ensure that it fits the need of that client. Also shower chairs. You know, you would think, oh, it's just a shower chair you throw in the shower. Well, you know, if I weigh 225 pounds and forgive me, Anita, I'm not saying what her weight is, but say she weighs 100, you know, she's going to need a lot different shower chair than I'm going to need. So again, we've got to make sure that we fit each individual with exactly what they need. And I can tell you a lot of stories. You know, we hear a lot of stories about individuals across the state who maybe haven't taken a shower in 3 months because they're in a wheelchair and they can't afford a roll-in shower. Or maybe they have family members who have to pick them up and carry them up to the house because their house is elevated and they don't have a ramp. So, you know, through the money you provide us, through our partnership with Medicaid, we're able to help individuals, you know, with those situations. Same thing with a ramp. You know, a ramp is not generic. It depends on how high the house is, where the driveway is, you know, if you have to have landings and things like that. So, again, our assistive technology department is very important in making sure that we maintain the best product we can for the people we serve. And then the last thing talks about transition services. We are allowed to transition individuals from the nursing home to the home if that's the case. So, you know, my concern there is, again, if you look at the cookie cutter approach where, you know, one size fits all, that is such a disservice to this program and the needs of the 4,000 folks across the state who rely on these services. Next thing is, you know, may limit choice is over there on page 7. Participant care, like I said, is self-directed. You know, the family, the client has the opportunity to interview their PCA. And again, you've got to remember, these are daily living skills. These are helping a person get dressed, helping a person bathe, fixing that person meals, helping them transition from the bed to a wheelchair or another mobility device. So, you know, it's so important that we provide choice for the people we serve because, again, if you have a disability, for example, and you're going to have somebody help bathe you, would you not want somebody that you know you rely on or somebody that called you and said, hey, we're going to send you such and such for the next 4 hours, you know, a day for the, you know, for however long you need them. So, again, choice is so extremely important. And then, like I mentioned before in that last bullet point, you know, we have our assistive technology division who really go out and make sure we meet the needs of every individual. Looking over there on page 8, that's the last concern. You know, I'm not convinced that it will reduce costs. You know, when you look at our program, we charge $13.28 per client per hour. And, we checked with some of the other private companies, and they were a lot higher than 1328. So we feel that we have a strong rate there that meets the need of the client, but also is efficient as well. And then the home modifications, durable medical equipment, those are billed at actual costs. We don't mark those costs up. We bill those to Medicaid at actual costs. And then the third bullet point, we talk about administrative costs. We're working with Medicaid through CMS, and we changed the way we're going to start billing administrative costs. So administrative costs are going to be billed at 50/50, which is drawn by 50% by the federal government, and then we match the other 50 through an appropriation that y'all give us. And then finally, background checks. Again, those are required by state statute. We have fingerprinting machines at all of our offices. Personal care attendants have to come in and be fingerprinted. And then we've got the agreement with public safety where they're doing background checks. And that's at no cost to the Medicaid program or to us, thanks to the bill I think y'all passed 4 or 5 years ago where state agencies can't charge other agencies. So public safety, unfortunately, can't charge us. So that is a free program that doesn't charge the Division of Medicaid. So, again, this program is so extremely important. It helps individuals. It helps families stay together. You think about if you had a family member with a significant disability, would you rather them be in a long-term care facility? So when you got off work, you had to come home, maybe grab a bite to eat, change clothes, and then go visit your loved one, or would you rather have them in the home with you? And in many cases, we can do that. Like I said, 4,000 Mississippians every year rely on this service, and it keeps families together. It allows family members to keep working. And it's just a great service, and I truly appreciate y'all giving us the ability to administer it. I tell you, Drew and Will are awesome partners. We work together a lot, and they've been great partners. The Division of Medicaid has worked really well with us, and hopefully they'll say the same thing about us. But again, it's truly changing lives, and we couldn't do it without y'all's support. So hopefully that answered the questions y'all wanted me to come talk about. I'll be more than happy to talk about anything dealing with our agency or anything else y'all would like for me to talk about.
All right. Thank you. And Chris, while you're there, I just want to compliment you and your staff on the way your agency operates. I know you've been very helpful with some of my constituents up in DeSoto County, and I'm certainly familiar with your work progress that you've done up with some of our companies up there.
Yes, sir. Thank you.
I do have a question. You mentioned you have a design team that goes out and take a look at these houses. For the modifications, do you do that in-house or do you contract locally?
Yeah, we have, our AT division has, I think it's called AutoCAD, which is the software program they use. So they're able to go out, look at the bathroom, determine what needs to be done, and then do the specs. Now, once we get the specs, then we put it out for quotes or bids if it's over 50,000. So we have a group of contractors that work with us, but under state statute, we do put those out for quotes or bids depending on what the amount is.
Thank you, Chris. We appreciate everything that your agency does. And I just want to thank you as well. Representative Hines had a question, and then.
Thank you, Mr. Chairman. Chris, I want to say, before I ask a question, I want to say something. Out of the 20 years I've been here, I've never had an issue with your agency.
Yes, sir.
Whenever I've called or suggested someone else call, your agency has always stepped up and responded timely and very proficient. And that's just a testimony to the type of people and the atmosphere you have in your agency. So thank you for the good and diligent work you do for some of the most vulnerable residents and citizens we have in this state. So
yes, sir.
Keep up the good work.
Yeah, thank you.
Tell me about your trauma services, head injuries, and stuff like that. If you can expound about what you do for those patients. And the reason I'm asking is I ran into one of your staff members, a young lady by the name of Allison, and she couldn't stop talking about what y'all do and all that. Yeah. But can you just kind of give me a little more about that, please?
Yeah. When you talk about our spinal cord and head injury trust fund, it used to be a separate trust fund. We used to get so much money from moving violations, DUIs, things like that. But a few years ago, I think y'all changed it. Now it gets swept into the general fund. So that's part of our general fund appropriation. But we use that, like I said, we have the spinal cord and head injury trust fund. I mean the home community-based waiver program where we serve individuals there. But with Allison, Part of what she does is, we do public awareness. So she's able to go out to schools and talk to kids about wearing their helmets, wearing bicycle helmets, things like that. But then we also have sub-grants where we give it to like Brain Injury Association, trying to remember. Yeah, William Hurd and Tupelo. So there are a variety of services that we can help individuals who have a spinal cord or head injury, whether they qualify for the waiver or not. We have that other funding source to provide services as well. So does that kind of help?
Well, the reason that there has been a large number of ATV,
Yeah.
three-wheelers and all that accident with children and adults, and I'm just trying to see how does a person matriculate through the system to get that. So if you don't have to discuss it now. If we need to be a sidebar,
Okay.
we can do that. But
Okay.
I'm interested in knowing more about that because I had a couple of people in my district that ended up having some major issues.
Okay. Yeah, in those situations, we can do home modifications and whatever that person needs. Now, we can't pay for hospital care or like if the person goes to, say, the Shepherd Center in Atlanta, we can't pay for that. But we can do home modifications and anything like that to help the individual, be as independent as possible in the home. And vehicle modifications, we can do those as well.
Thank you.
Representative Scott?
Yeah, I have three questions. First of all, I want to thank you as well for what you all do at rehab. But honestly, the main questions that I get from people is the disability determination services and how long, the whole process and how long it takes for those determinations to be made. So my question to you is, do y'all need some additional staff, or is there something that we can do from the legislative standpoint to help you guys to facilitate those services for people?
Yeah, I'll tell you, through our DDS program, it's 100% federal. There are no state dollars associated with administering that program. So from a state standpoint, that's good in that you don't have to put in your state dollars in it. But on the flip side of that, because it is 100% federal, we have to get approval from Social Security Administration. So, they have to give us the approval to hire additional examiners. I would love to say, oh, we need 10 more examiners. Let's go through Personnel Board and get them. But Social Security Administration requires us to go through them to get approval. And to be quite honest with you, they've had a freeze. Isn't that right, Christy? They've had a freeze for the past few years to where we couldn't handle or couldn't hire additional examiners. I'm trying to think, it's about 60 days? Is that the average? 60, 70 days? I'm looking at Christy back there. It's about 60 to 70 day turnaround from the time the person files disability till the actual time we make the determination. But to be quite honest with you, a lot of times it's because we're waiting on medical records. I know there are a lot of times where our examiners have to call many times to the doctor's offices to say, we need records for so-and-so to make a determination. So, a lot of times it's not so much our examiners, taking a lengthy time to make that determination. It's waiting on medical records to make an accurate determination. So, I would love to give you a list of things to help, but with us being 100% federal, again, we're relying on Social Security Administration to release the ability to hire additional people. And then, like I said, a lot of times we're waiting on the doctors to submit the medical records to make those determinations.
But, so then there is something that we could do, that you all could come up with some best practices on trying to address this medical records situation. And if we were to put some money in there for staff, that would then help you all to then, your examiners to be able to expedite the situation. That would help, wouldn't it?
Right. Yes, ma'am.
So that would be a good recommendation from you all to make to us.
Okay.
That the state could do, right? To help.
Yeah. Yes, ma'am. Yes,
Okay, so I'm putting that down because I think that's important. The other thing is the 10 sites I'm excited about, the Project Search program. Is Laurel in one of those?
Ma'am?
Is Laurel, Mississippi in one of those?
Yes, it is actually. Yeah, we
Okay,
have
I
one
thought
in
I
Laurel,
had-
we have one in Hattiesburg.
I
and,
thought I had heard
yeah.
something. And then on the TBI, can you, that is done in slots, is it not, that
It is.
participation?
Yes, ma'am.
Okay, so are we at capacity there?
Our waiting list right now is about 1,000 individuals. So
Okay.
we are able to add additional people. Our counselors across the state are doing those initial evaluations. But to be honest with you, with COVID right now, sometimes we're being told by the client, when we call to say, hey, we're ready to come do the initial evaluation, they're like, oh no, I don't want you in my home right now. So, we're running into that a little bit right now where we have the availability, but clients are saying, we don't want you in the home right now because we're scared of getting COVID. So it's kind of a dual-edged sword, I guess, so to speak.
Okay, so the things that we do are prospective then, Chris. So let's just say that at some point in time, we hope that COVID will be defeated. We escalated your slots.
Yes, ma'am.
Before.
Yeah.
Would it at least be your recommendation that we would escalate at least that level again? Because once we get back with 1,000 people waiting, and of course that was minute what we did, but with 1,000 people waiting, I think you want to take this opportunity to say to this committee that even though we're in an extraordinary situation with COVID, but I think you want to say to us that look prospectively in a normal situation that you do need an escalation of at least what we did the last time.
Oh, yes, ma'am, definitely. I mean, like you said, with the waiting list of about 1,000 folks, I mean, there's definitely the need out there. So if we were able to get additional funding, COVID were to lighten up a little bit to where, folks felt comfortable us coming in the house, we could definitely utilize that funding. Yes, ma'am.
All right. Thank you. Thank you.
Yes, ma'am.
Thank you. Rehab. Thank you.
Thank you.
Senator Blunt.
Thank you, Mr. Chairman. Thank you very much for your presentation and the good work y'all do. I'm interested in the background check process that you mentioned. I think I heard you say that cost was previously paid by the department, where you would essentially pay the Department of Public Safety for conducting the background check, but now you can't do that anymore until the Department of Public Safety bears that cost. Is that correct?
That's correct. Yeah, it used to be an intergovernmental transfer between us and public safety, but then when that legislation happened, I can't remember how many years ago it was, where agencies can't charge other agencies, and then we no longer get a bill from public safety.
When you were doing it prior to that bill passing, was that a Medicaid expense? In other words, were Medicaid dollars paying for that?
No, sir.
So
we absorbed that through our budget because we didn't have a code to charge Drew. So
it's not a matchable cost that you were able to charge Medicaid for.
No,
okay.
Sir.
Thank you.
Seeing no further questions, thank you, and appreciate your presentation.
Yes, sir. If I can do one more thing, I forgot to. Christy Embry, if you'll raise your hand, and Anna Tucker, I'm gonna call them out. They're both here at the Capitol during the session every day. Christy really focuses on the DDS claims. Anna does the vocational claims. So they're here. So if you ever have a constituent issue or a concern or anything, find them, and they can definitely, we can make sure we get that information taken care of.
Thank you, Chris.
Yes, sir. Thank you.
On behalf of Chairman Hood and myself, I certainly want to thank everybody, all the committee members from the House and Senate Medicaid for attending. We appreciate all the presenters. We heard from over 22 different provider groups over the 4 days of hearings. I know I'm taking away some information and things I did not know, and I hope that's the same for the rest of the members. I want to give a particular shout out to the staff, Carlos, Anna, Tammy, and Janet, for all the work that they did in making these presentations go smoothly. And if they're not already on there, it's our intent to put as many of the presentations on our legislative website. Okay, so that'll be up there soon. So anybody wanting to take a look at and reflect back on what was presented, you'll have that opportunity to do so. Chairman Hood.
I'd just like to thank everybody for coming and presenting, and the House and Senate members being here. I think everyone in the committee has come back with more knowledge, and I think as we proceed in the session that these hearings are going to be very beneficial for the state and the members. So I'd like to thank you for coming.
Rise and report.
We reported because we voted. Hey, give me a report.